Good afternoon to you all. I also would like to congratulate festivities of the 14th of March. There are fear networks in anxiety disorders, and we know that it has a relationship between the treatment procedure. Amygdala, hippocampus are active in the fear networks. Amygdala has output towards hypothalamus, locus ceruleus, periaqueductal gray matter, and parabrachial nucleus. Related with these centers, there are arousal symptoms, whereas hippocampus is related with the reenactment of fear. You see hippocampus, you see medial prefrontal cortex, you see the thalamus, through hypothalamus, paraventricular nucleus, from paraventricular nucleus to hypophyse, and towards the adrenal glands. Corticoids increase, lateral nucleus, through lateral nucleus, central nervous system is activated, locus ceruleus through the neuronergic system shows an activation. Periaqueductal gray matter in freezing is associated with freezing behavior, which is equivalent to avoidance. Parabrachial nucleus is associated with increase in respiration. SSRIs, the effect of SSRIs bottom down, is said to control this activation. What is the idea based on these things? In anxiety disorders, there's an activation of the fear networks, and the fear networks activation is associated with the clinical picture. If the fear networks, if it was possible to control the fear networks, then would it result in a treatment? Was the question asked. In anxiety disorders, could this be beneficial? Anticonvulsant drugs, as we all know, basically decreases the decharges from epileptic neurons and controls convulsions. And by inhibiting the neuronal activation of the fear networks, controlling anxiety symptoms. If anxiety is in relationship with the fear networks, then anticonvulsants should be able to control anxiety along with their anticonvulsant effects. Anticonvulsants, and how do they exert their action? They exert their actions through channels, primarily sodium and calcium channels. They use the ion channels to show their effect. Lamotrigine, carbamazepine, oxcarbazepine inhibit repetitive firing by blocking sodium channels. Let's look at the calcium channels. Similarly, calcium-dependent ion channels activation and the inhibition of the activation of these channels are responsible for the action. If you block the calcium channels, then you also block certain excitatory neurotransmitters like substance P, like glutamate, like noradrenaline. Anticonvulsive effect is exerted through the blockade of the channels, and through the neurotransmitters it allows you to exert a control and symptom alleviation. Anticonvulsive effect is seen through the blockade of sodium and calcium channels. Glutamate, the inhibition of glutamate release is very important, and classically the increase in GABAergic activity is associated with anticonvulsive effect. In anxiety disorders, the GABAergic inhibition and the enhancement of the GABAergic inhibition and calcium channel modulation are the areas of interest for us in the treatment of anxiety disorders through anticonvulsive drugs. What do we base this on? We base it on certain studies. There's a study reporting GABA dysfunctionality. A study has found dysfunctionality of the GABA was associated with anxiety disorders. GABA receptor binding and GABA levels were found to be low in anxiety disorder patients in neuroimaging studies. GABA-A receptor subtype, its arousability was found to be involved in anxiety. This is a PET study. In panic disorder, GABA-A benzodiazepine receptor binding was found to be globally decreasing. Based on these findings, the agents at hand, like the benzodiazepines, which we talked about a while ago, and the barbiturates, stimulate GABA-A receptor. Tiagabin inhibits GABA reuptake and directly increases GABA, and vigabatrin inhibits the enzyme metabolizing GABA and therefore increasing GABA levels. Apart from GABA, voltage-gated calcium channels are very important, especially pregabalin and gabapentin studies where pregabalin is more prominent. Voltage-gated calcium channels, when they are blocked, stimulating excitatory neurotransmitter, there is a regulatory effect on the excitatory neurotransmitter. Pregabalin and gabapentin are GABA-related. They are not related with GABA. Only their names are associated with GABA. Previously, it was thought to be related with the GABA. However, their names are only reminiscent of GABA. They actually exert their effect on the calcium channels. I want to emphasize some of these mechanisms. Calcium channels and the anticonvulsive drugs that we use. There are different calcium channel types. Among these, especially lamotrigine and pregabalin and gabapentin seem to be more effective. Anti-glutamatergic effect is seen with lamotrigine and topiramate. Lamotrigine and topiramate are effective in both. Carbamazepine is at one hand, valproate can be added on as well. When you look at it, these two systems are becoming more prominent with anxiety. Tiagabin increasing GABA shows limited response, especially the research on calcium channels and antiglutamatergic mechanisms show to be more promising. Let's look at the studies. In generalized anxiety disorder, we were talking about pregabalin. There are 7 double-blind, placebo-controlled studies about pregabalin. When we look at these studies, most of them having compared with benzodiazepines, venlafaxine comparison study, there is one venlafaxine comparison study, but there is no comparison study with SSRIs. There is no evidence about dose-response relationship. You cannot say that the higher the dose, the greater the response. It's not possible to say that. I want to underline one factor. Almost all of these show that pregabalin is effective, but I want to underline one factor. Hamilton anxiety scores tell us about the response, treatment response. In placebo-controlled studies, although it seems to be effective in all of these studies, it has only proved to be effective by 4 points in Hamilton anxiety scores. We should be aware that it's effective. However, we should also be aware that its effect is very limited, just by 4 points of decrease in Hamilton A. Effect is earlier in comparison to venlafaxine. At week 1, you can see the response. The recommended dose is 300 to 400 milligrams per day. 2 times a day, 3 times a day dosages show no difference in terms of effect. Valproate is there is only one study by Aliyev and friends, which is a double-blind placebo-controlled study. it was found to be valproate was found to be effective, but this is only a single study. Another study by Tiagabin, the results are ambiguous, conflicting. In one analysis, it's negative. In another analysis, positive. Early effect. Tiagabin increases GABA directly. It's potent, but no potent effect has been shown. What about panic disorder? Double-blind, placebo-controlled gabapentin study. The result is slightly different here. The patient, when you look at the patients receiving treatment, gabapentin is not found to be effective. However, when you look at the PASS points, panic agoraphobia scale points, if you look at the patients whose panic agoraphobia scale points are higher than 20, gabapentin seems to be positive. And the researchers say that gabapentin was found to be effective in severe panic disorder patients. Again, valproate in panic disorder was found to be effective. However, it was only 12 patients. When you are looking at these studies, you have to check the patient numbers. Of course, 12 patients mean that this evidence is limited. What about social anxiety disorder? Let's see what we have at hand in the social anxiety field. Gabapentin study, double-blind, placebo-control, significant improvement, but a single study. Pregabalin study. In social anxiety, pregabalin and gabapentin acting on the calcium channels seem to be more studied, and we see that the pregabalin is significantly effective. PTSD and lamotrigine, along with topiramate, we know that was using most of the mechanisms of action on the list. Let's look at the numbers here. The result is positive, but only 14 patients, and response was compared to placebo in only 4 patients. So this is very limited evidence. In OCD, there are no double-blind placebo-controlled studies. I have topiramate, but this stands as an example for all the other open-label studies. Let's look at the meta-analysis. First level, repeated control studies or meta-analysis. Second level, a random controlled study. And third level, 10 or more cases which are not controlled. And the fourth is those studies which are not controlled. Panic disorder, gabapentin. In severe panic disorder cases, we said that gabapentin was effective. That's why there's a question mark there. Valproate was found to be effective in panic disorder by Aliyev and friends. But it's a single study, therefore its evidence level is 2. In OCD, there is no level 2 evidence because there is no double-blind placebo-controlled study. PTSD, with lamotrigine, you know that the patient numbers were very limited. Social anxiety disorder, pregabalin, gabapentin were shown to be positive, but they were single studies. The sample sizes were adequate, but the studies were only single studies, isolated studies. Pregabalin and valproate in generalized anxiety disorder. Pregabalin seems to have the most powerful evidence in generalized anxiety disorder. In generalized anxiety disorder, pregabalin and valproic acid are effective. However, pregabalin has the strongest evidence. But the difference is only 4 points of difference in Hamilton anxiety. I just wanted to remind you this. In social anxiety disorder, gabapentin and pregabalin is enough, but single studies, isolated studies, panic disorder, valproic acid, lamotrigine in PTSD, there's a question mark because the sample sizes are very small. In conclusion, in anxiety disorders, anticonvulsive agents, based on the evidence at hand, their effect can be said to be limited. However, especially pregabalin, gabapentin, and valproic acid, maybe for lamotrigine too, if we are to have an effect, for the effect to show itself, we should say that there are no studies showing this effect with adequate sample sizes, and perhaps showing us the way that these areas are appropriate areas of research to add on to the literature. The meta-analysis need to be performed again after